And now you all see that the refractive surgery is changing from examer to femtosecond, and lenticular removal is the in thing, and many companies are now offering. So let us hear from a very good surgeon and from the family, the Rushad Shroff, about his experience for the Silken touch lenticular extraction made easy.
Thank you, sir, for that kind introduction. So this is, we are doing our lenticle extractions on the ELITA platform from Johnson & Johnson. The key features of this platform is one, it's a very low energy laser. It's one of the lowest energy lasers out there in the market. It's an extremely fast laser with a 10 megahertz repetition rate, and the spot size is very small with almost no spot separation. That ensures tissue bridge free dissection of the lenticule. The other unique feature of this is the biconvex shape of the lenticule. This has been shown in confocal studies to cause less damage to the subbasal nerve plexus. There's better matching of the anterior and posterior lenticule surfaces, and when we looked at OCT to see Bowman's wrinkles that affect the quality of vision, we did not find them to any extent in this particular technology. And it has a non-refractive flat ad with a ring cut, which makes it easier to actually remove the lenticule. So with this in mind, we were one of the first sites to do the limited market release for this, and these are a few of our learnings. One of the things about femto lasers is that each laser is different. Each laser's glass burn threshold from where you set the energies is different. So it always takes you an initial few cases to get your energies optimized. The general principle is to go with higher energies and then come down on the energies, and that makes
Please.
the dissection a little bit easier. This is a video just showing that the optimizing the ocular surface is very, very important in lenticle extraction procedures. So you have to not leave the surface either too dry or too wet. It's important to use a Vexel sponge to optimize the surface before firing the laser, as well as before extracting the lenticule. Regarding the dissection technique in this, it's pretty similar to the existing lenticule platform from Smile. The only thing is, because of the biconvex shape, it's important to tent up a little bit more. It's kind of like kicking a football when you enter the anterior plane. And while going into the posterior plane, it's like diving into a swimming pool. You have to dip down a bit more. The rest of the procedure is fairly similar. As you can see here, the dissection is relatively easy. There's not much resistance being faced, and you can clearly and easily see that it's being dissected out in pretty much one or two sweeps. It's always important at the end to inspect the lenticule just to make sure that you've got the lenticule out completely and there are no tags or remnants. And in the cases we've done so far, which is about 105 eyes, we haven't had any retained lenticule in any case. So coming to the meat of the talk, which is our results, it's important in these technologies to assess efficacy and safety. What you can see from our data is that 95% eyes were 20/20 or better at 1 month post-operatively. In terms of the safety, there were no patients that lost 2 or more lines of vision. There was a patient who had a epithelial defect who lost about 1 line of vision at 1 month, but no one with 2 or more lines of vision lost. The accuracy of the spherical equivalent attempted versus achieved, as you can see here, it's quite tightly packed. The initial nomogram, there was a little bit of undercorrection, but with the subsequent iteration, that got better. And as you can see here, the percentage of eyes within, this is taken on the autorefractometer, within 0.5 diopters is 67%, and within a diopter of the spherical equivalent is 90% at 1 month post-operatively. In terms of astigmatic correction as well, you can see that 75% eyes were within the targeted 0.5 astigmatic correction, and 97% eyes were within 1 diopter of the targeted astigmatic correction. Another bugbear has been the recovery post-lenticule extraction surgery, and we can see here that there is a fairly good recovery. The average uncorrected visual acuity is about 0.1, which is not bad. That's about 6 by 7.5. And what we did was we actually divided these eyes into learning curve and non-learning curve eyes, and you can see that it's come down from about 0.15. In the next 85 eyes, it's almost at 6.6 on the first day. So after you get over your energy optimization and your learning curve, you actually manage to get pretty good wow effect or good outcomes on the first day itself. Regarding aberrometry, we looked at the eye trace system, and we found that there's no significant induction of aberrations, again, which is very important in a refractive platform. In fact, there is a trend towards reduction of corneal spherical aberration, And this provides excellent quality of vision to the patient post-operatively. There was no significant induction of coma or trefoil in these patients. And this is just an example illustrating the same on the eye trace system. This was done at a 5 millimeter pupil size. And this is a graph just to illustrate the same. Regarding contrast sensitivity, as was shown by my previous speaker, there is a slight decrease in contrast sensitivity, but again on the eye trace at 10 cycles per degree, it's maintaining more than 50%. So that's a pretty good contrast, and it's not a significant drop in contrast in these eyes. We also looked at dry eye data and found that the lipid layer thickness and the non-contact TBOT were were well maintained. Again, no significant change in this in the post-operative period at 1 month. We also looked at the ocular surface thermography. That's another device that we are using to study the ocular surface temperatures. We did a small study comparing lenticule and flap, and you can see that blue tracing of the lenticule, the severity score or the impact on the ocular surface immediately post-operatively dips down, and even at 1 month, it's below the baseline. So it's maintaining the ocular surface better, whereas in LASIK, it tends to go up from baseline, showing more impact on the ocular surface as is expected with a flap-based procedure. To take home, basically the points are that the ELITA system has a short learning curve. We've found excellent immediate post-operative visual recovery. There's no significant induction of aberrations. There's no significant increase in dry eye. The thermography is better than flap, so the ocular surface is better maintained. But like with any laser, it's important to understand your laser, modify the energy settings and dissection technique and instruments as per your comfort. Thank you.
Thank you, Rushad, for sharing your experience about this technology. May I have a question that how many patients you think now will shift from examer to this lenticular extraction technology?
Sir, I think lenticule is going to be the future going forward. However, at this point in time, there are still a subset of patients where you will require examers. So these are complementary technologies. You can't say currently that every patient can be done on lenticular extraction platforms. A lot of surgeons are doing predominantly lenticular extraction, but in our practice, I would say it's almost a 50-50 right now. So
Yeah.
there are cutoff criteria for each procedure.
Yeah, now it is not the day the exam will go away. Definitely, if hyperopia is coming with the lenticular, then it will have more number of patients. And there are other issues like cost is also issue in India
course,
particularly. And examiner is not doing bad results. It is giving very good, excellent results.
Exactly.
So it has to stay. Yeah,
It's
I
there
agree
to
with you.
stay.
Thank you.
Yes.
Like for smile, we have 250 micron, like 120 micron below which.
Yeah. So this cap that we had set in these patients was 110. You can set it a little bit deeper, but the initial recommendation from the company was 110, and that's what we've actually used so far in these eyes.
For Ismail, we have plano cap. Here we are not having a plano cap. It is thinner in the center and thicker in the periphery. So if you go deeper, you will go more deep in the area where you are going to have a dissection. So it is better to keep 110 in this, but Ismail you can go up to 120, 130. I commonly use 120 for Ismail. Yeah.
Thank you.
Any questions? We have just 2 minutes. No, 11:15 is the next session. I am the first speaker, so no worry. I am here only. But any questions, any comment from the audience? But I think the time has come when the cataract is becoming refractive surgery, so these kind of sessions are of very important. And I think I must thank Dr. Bianchi for giving importance to sulcus examination before implanting a phakic lens. I was just doing personal discussion for the cyst in the iris. If we can localize it well, and he agreed to it that we can do a peripheral iridectomy over the cyst, so it will get plain. So in those cases, it can be of help. He said that I will do a study on this, but this is one idea. Anything you want to comment on, particularly MIGS for cataract surgeons? I think many patients of cataract, even pre-operatively, are not having control on 2-3 medicines for glaucoma. So it will be good that if we all can learn from Dr. Sushma to do MIGS or take a help from the people who are in and around your practice for doing the glaucoma management along with the cataract surgery. I think that is a very good approach. We had a very limited experience with this, but we found it works well. We used mainly the 25 gauge needles, and we have used stents also. But we have not used any KDB. But I think cost is an issue for KDB, so the Indian replacement of needle will be very good approach. Thank you very much.